right. Got it. Okay, thanks everybody for being here. Unfortunately, I don't actually get to go to Haiti anymore. It's been a little unsafe and I do miss that, but it was a fun opportunity while I was able to go. I really enjoy opportunities to speak with patients outside of the clinic. This is kind of a unique and fun opportunity for me. I do a lot of pain management, symptom management teaching, but usually to medical professionals. So it was really fun for me to kind of design this for the patient. So if you'll next slide. At the end of tonight, I am hoping that you have a better understanding of what pain is. There's lots of components to pain. Feel more empowered to advocate for pain that you might have, and kind of understand how to partner with your providers about pain, because sometimes there's language and things that can be helpful so that providers will really listen to what you have to say. I want you to be familiar with tools available for pain management, and we're going to talk a little bit about safe opioid practices, because that has kind of influenced how pain management in the oncology setting works, even though the oncology setting is not the place where we see a lot of addiction, overdose, et cetera. But we'll talk about that a little bit more. Next slide. So I just want to start with kind of the understanding that pain is a signal in your nervous system, and it's designed to tell your body that something is wrong. And in general, pain is considered an unpleasant sensation. It's built into your brain, and your brain is keenly aware of circumstances and surroundings. And yet it can be kind of stupid, because your pain signal might say to your brain, hey, something's wrong. And we don't have a super good mechanism for overriding that and saying, yeah, I know, it's okay, just quiet down. And so there is some that can be done, kind of this mind-body connection, but a lot of it is more than that. And so we'll talk a little bit tonight about different ways that we can work through those signaling processes. Next slide. So there's I'm going to give like a pain primer, more so you kind of understand how medical professionals look at pain. We identify pain as acute or subacute, so kind of short-term pain, which is considered less than 3 months, more often caused by cancer or cancer therapy. So it might be surgery, radiation, some kind of diagnostic procedure, a port placement, infusion-related pain, mouth sores, things that come from treatment, but that are expected to kind of recover pretty quickly. And that's more kind of acute, subacute pain. And then oftentimes what we see in the metastatic setting is more chronic pain. That's the next slide. Also, feel free to chime in, ask questions, chat. I really like to have a dialogue. I was just saying to Rachel how much I miss teaching in person, because I feel like people get more engaged and interactive when you're in person. But please don't hesitate to ask questions, interrupt me if there's something that strikes you where you really want to understand better. Chronic pain, by definition, is pain that's considered to be more than 3 months. In the metastatic setting, we're more often seeing this by tumor, tissue destruction, neuro changes, like from the therapies that we use. We use a lot of taxanes in like Taxol chemotherapy, and that can cause like neuropathic changes that can be very chronic. Oftentimes that pain is more than one site. People might have neuropathic pain from that Taxol chemo, and they might have an active tumor pressing on something. They can have lots of different types of pain, and pains that last a long time. And I also wanted to say, following completion of curative treatments, or in patients that have no evidence of disease, but we expect that we may see disease again at some point, up to a third of people will have chronic, what we call kind of non-malignant pain, but it's pain that's related to their cancer or cancer treatment. And we still want to manage that under the cancer pain kind of umbrella, which is managed slightly different than the non-cancer pain, actually pretty significantly different than the non-cancer pain. Next slide. So one of the things that are really important as a patient to come kind of prepared for is to help your provider understand what your pain story is. And I'll say, what's your pain story? Patients with me as a palliative provider get extra time, and we can really dive into kind of very deep details. Oftentimes with your medical oncologist and their team, it's a little bit quicker. So you want to kind of come with these things in mind. Where is it? How does it feel? Is it sharp? Is it dull? Is it achy? Like, have some descriptors, and we'll talk about why here in just a minute. We want to know how bad it is. I hate the 0 to 10. I don't think it works for everybody, but it gives a benchmark for us to kind of give a measurement to the pain, and that's important. We want to know how long it's been going on, what makes it worse, what makes it better, has something been done that is really helpful or not helpful, and those kinds of pieces of information can really help your team figure out with you and for you what the best management strategy looks like. Next slide. So I really like the idea that we manage pain with two different kind of measurements. One is the 0 to 10. I already said I don't care for that as much, but I also really like to have patients help me understand, what is pain keeping you from doing that you would otherwise do? So is it keeping you from doing things you want to do? And if so, what are they? This is the thing, when you can really help people understand your story in ways that are practical. Like, man, I used to be able to go walk to the park with my kiddo, and now I can't do that anymore because of the pain, and that's something I really want to do. That sense of story brings some, I don't know, just interest, like it hones in. It's not just, well, I'm having pain, can you treat it? It's, hey, I'm having pain and this is how it's impacting my life. And people who go into healthcare go in to help people, and if you can help them understand really what we're helping, then there's psychologically just a little bit more interest. I think things like, have there been times when your pain has been treated as well as you like, or has not been treated as well as you like? And can you help us understand what those situations were like? When pain has not been treated effectively, there's a bit of trauma in the brain. And so helping us understand that took place and under what circumstances that took place can help us better manage your pain going forward. How does your pain impact your functionality? We kind of just talked about. And how does that impact your joy or hope? Because those are the things that drive you forward every day. We know that living with a chronic illness like metastatic breast cancer is a job. And the work is learning how to live in the balance of treatment, sometimes multiple modalities, lots of symptoms, things that really impact your life. And also kind of just the background knowledge that you're carrying this around and it impacts every part of your day. And so if we can, as a medical community, help you to manage symptoms such that you're functional, you're functioning better, and we can restore some of your joy and your hope and take away maybe some of your fatigue and unpleasant symptoms, that's a win. That's a win for everybody. So helping your team understand that in a practical way is really important. Next slide. So we kind of already talked about this, 0 to 10, FACES scale. There's a way to measure suffering. That's a concrete measurement, but more now we're really looking at function. How does your pain impact your function? When we use medications and other modalities for your pain, is it increasing your function? And if so, that's a win. So we always want to see the 0 to 10 number going down, but more importantly, we want to see you functioning better in your day-to-day. So next slide. I'm going to talk about the different types of pain, and this is kind of important because there are essentially 3 different types of pain signaling in the body. And depending on what's causing that pain signal, actually kind of 4. There's 4. Depending on what that pain signaling is triggered by, we might choose different tools to treat it with. And I think this is important because sometimes people don't understand why I would choose one medicine over another. And I try really hard to help patients understand why I'm choosing what I'm choosing, helping them understand what's going on in their body. Sometimes I'll use their scans and pictures as an example, because really it's important for you to know what's going on in your body. So somatic pain, this is the pain that most of us think of when we think of something painful. It comes from damage of skin, tissue, muscle, bone, pretty much everything. It can be a superficial, so like a hangnail is a type of somatic pain. And if you had your leg cut off, that would be actually a mixed pain, but somatic would be the majority of it. It can be described as dull or achy. There's other kinds of words that we use, sometimes sharp, but less so often. Next slide. somatic pain tends to respond medication wise well to things like Tylenol when it's mild to moderate, anti-inflammatories like ibuprofen or naproxen when you're in that kind of mild to moderate, and it can be used in conjunction with things when your pain gets moderate to severe. And oftentimes in that moderate to severe, we're looking at opioid pain relievers. People often ask me about what role cannabis plays in pain. And I would say cannabis plays a role in pain, but oftentimes cancer pain is significant enough that you're not getting a lot of bang for your buck out of cannabis. If you do, it's probably in that kind of mild to moderate. Once you get to severe, it's kind of you get less out of it than you would other medications. And then there's a lot of non-medicated modalities that we'll talk about that can be helpful with somatic pain as well. Next slide. So the next type of pain that I like to talk about is neuropathic pain. And this is the pain that is from damaged nerve tissue. So that can be nerves out in your periphery, like your hands, your feet, your legs, or it can be kind of central, more spinal or nerve root. It can be a chemical alteration of the nerve. So that's where like things like Taxol chemotherapy and some of the other chemotherapies we use create some damage to nerves. We don't fully understand exactly why or how, but it can be excruciatingly painful for patients. So think about things like pinched nerve or tissue injury. People describe neuropathic pain with some pretty specific language. They'll say shooting, like it goes from here to here, or it wraps around, pins and needles, burning, electric. When they use words like that, I know we really have a nerve component to your pain. So part of why we ask you to describe your pain is helping us figure out what kind of pain are we dealing with. Next slide. So neuropathic pain tends to respond better to non-opioid medications. We have a class of medications that are like an old seizure medication that we don't actually use in seizure management anymore, but we use it a lot because it works well for neuropathic pain, called gabapentin, and another medication called pregabalin. Some people know this as Lyrica, that tends to work better on kind of neuropathic and what we call myalgic, which is like this kind of everything hurts kind of pain. Antidepressants such as duloxetine, which is also known as Cymbalta, can be used. It was actually introduced for antidepressant, and also at the time that it was approved by the FDA was found to help people that had diabetic neuropathy, which is what made the oncology group kind of go, I wonder if that would work for chemotherapy-induced neuropathy or neuropathic pain. And in some patients it does, not in everybody, but it actually has better data for chemotherapy-induced neuropathic pain than the gabapentin does. So, sometimes I'll say to somebody, I think we should start a mood stabilizing medication, but not for your mood necessarily, for this neuropathic pain. And it makes people sometimes question. But we do know that brain chemistry is a part of the brain signaling pain process. And so it kind of makes sense that some of these mood stabilizing meds might have an impact on our pain signaling. Neuropathic pain can respond to opioids, but it tends to take higher doses. And we're always trying to create a goal of the lowest opioid dose possible. That's just for, side effect management and safety and all kinds of things. We'll talk about that a little bit further into the talk, but we're always looking for non-opioid ways to manage pain. Methadone is a drug that a lot of people are familiar with as a drug that is used to manage heroin cravings, but it's actually something we use in oncology pain a lot because it's a great medicine that works on complex pain syndromes. So that's pain syndromes that are usually a mix of somatic and neuropathic or visceral, which we're going to talk about in just a second. And methadone can be really helpful in managing all those pains. Even though it's technically an opioid, it tends to work better for neuropathic pain. And then there's also things like interventional nerve blocks, and we, can use those to help with nerve pain, and that can be a really effective management strategy. Okay, next slide. So this is kind of the, forgotten pain. It's called visceral pain. This is the kind of pain like when you're a kid and your tummy hurt and you know, your mom's like, where does your tummy hurt? And you're like, I don't know, it hurts everywhere. Because it's pain that arises from generally inflammation or sometimes implantation of tumor to the lining that lines your abdomen, your chest, like around your lungs, around your liver. And the interesting thing about this pain is it's really diffuse. Like you might have, you know, something causing a stretch on this lining that's kind of down in the bottom of your lung on CT, but you kind of feel it through your whole right chest. That would be visceral pain. It's very non-localized. So it tends to be when people like wipe their whole belly and say, yeah, it just hurts everywhere, or sometimes it hurts here and sometimes it hurts there, I think about viscera. And so that's usually kind of a naggy, achy, sometimes a squeezy type pain. When it comes to things like lungs, it can be worse when you breathe in deep, better when you exhale. So when people are describing that kind of pain, then I'm thinking viscera. Next slide. So visceral pain can be treated with sometimes nerve blocks, especially if it's like pelvic and abdominal pain of certain sorts. It tends to respond to anti-inflammatories or steroids, and sometimes opioids can be helpful as well. So it's usually a bit of a mixed bag, and sometimes it's about figuring out exactly what's causing it and kind of coming at it from that perspective. Okay, next slide. So, and here's kind of the fourth type of pain. You know, this is total pain. This is kind of arises from the understanding that physical pain perception has an existential component, meaning like it's just tough to live. You know, we have psychological distress, sometimes anxiety, depression. We have spiritual distress, kind of thinking about our own mortality. Sometimes people have social stressors, relationship issues, you know, social determinants of health, things like housing insecurity, food insecurity. All of these things we now know make the perception of pain amplified. Doesn't mean pain's in your head. It just means when you have these stressors, that perception of pain can be amplified and bigger. So we have to account for that as a part of the pain process. Okay, next slide. So your individual experience of pain is very individual. You know, components that affect your pain perception start early in life. You know, adverse experiences, especially in childhood trauma, but also later in life as well. Everyday stressors like that we talked about. You know, your health experience, how much can you trust your medical team? There's actually, you know, that ties into how you feel your pain. If you feel like it's being managed well, it feels better. If you feel like it's not being managed well, it's going to feel worse. Your individual coping strategies, you know, how are you coping with life's stress? Because we all have it, and cancer certainly does not make it easier. Your social support system, those that have a better, more robust support system are going to have less pain than those that are suffering by themselves. And then the chronicity of pain, you know, if you have pain that kind of comes and goes and it's well managed and you know that it goes away, that's one experience of pain. Another experience of pain is somebody who's had a lot of physical pain or existential pain that's never been addressed, and it's just chronically a part of you. And that is a different pain perception. And, you know, just brain changes. So, you know, chicken or egg, does pain cause depression? Does depression cause pain? And the answer is yes. You know, brain chemistry changes can alter your perception of pain, as can gut chemistry changes. So that's kind of an interesting thing too. All right, next slide. All right, so now what? You know, you kind of have a basic understanding of what the different types of pain are. And if we have an understanding of the underlying cause of the pain, we're going to be able to better utilize effective strategies. We want to limit the need for unnecessary escalation of the doses of medications, because that causes additional side effects. Anytime you have a med, there's that potential for side effect. Not all cancer pain needs to be treated with opioids, but a lot of it does. And really, truly, opioid development were for things like cancer pain. You know, the persistency and the severity of pain that comes from cancer is very different from other types of pain. And if you kind of look back historically, this is the population that opioids was really designed for, people that have significant pain that doesn't go away. And then, you kind of have to sit back and think about, like, how do you feel about all this? What does this mean for you? How can you be in tune with your body? How can you better understand what your providers are telling you about your illness and maybe tumors that are active and where they are in your body? And does that correlate to the kinds of pains that you're experiencing? And then, be able to describe them better, advocate for yourself a little bit better. Okay, next slide.
Can I ask a question about that?
Yeah.
So I'm wondering, I don't have that level of pain and I don't need opioids right now, but I'm wondering if people that are at that point are able to still continue to work with taking an opioid prescription.
100%. Yeah. So the answer is generally yes. Some of it has to do with individual sensitivity to opioids. So I have some patients that can take an entry-level dose of an opioid and feel fine, feel like, oh, it manages my pain. It doesn't make me sleepy. We always have to watch for constipation, but that's not something that interferes with your ability to work. I have some patients that are so sensitive to opioids that we just have to do super tiny little doses because it makes them really sleepy. So a lot of it just depends on how you respond, but I have a lot of patients on chronic opioids that are still able to work.
Thanks.
Yeah, absolutely. Next slide. Okay. I want to be thinking also about strategies that don't require pills because, like I said, not all cancer pain needs to. Maybe it's not to that level. Hopefully it never gets to that point, but you might have pains that kind of come and go, or some of those, acute, subacute kinds of pains that are temporary. The mind-body connection is strong, and there is a certain amount of downregulation of pain perception that you can do through mindfulness and meditation. I think I have another slide on this, but it was interesting. I read an article and it talked about how significantly just the introduction of mindfulness, people were able to reduce their pain. And I think some of that speaks to this idea that we live in a culture that is go, 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 create, produce, and we often are not super connected with what our bodies are telling us. Like, I work 8-hour shifts and see X number of patients, and I don't have time to pee. So I don't always hear my body say, hey, I got to go to the bathroom, because I'm just tuned out and focusing on everybody else. But stopping and taking a moment to connect to my body and listen to what my body needs actually significantly reduces my stress and makes my day better. If I take that 3 minutes to go to the bathroom, I'm less stressed. My brain is dealing with one less signal. I think also just the idea that we validate ourselves. We have these kind of couple different parts of our brain. We have our lizard brains that keep things running and going, and we have our frontal cortex that has us thinking, but there's also kind of this emotional center in the middle that needs a little bit of validation. And sometimes just like pausing to say, oh, yeah, I'm stressed. I wonder what that stress is coming from. Oh, well, my toe's been hurting me all day and I haven't really paid attention to that. And kind of just recognizing it, honoring it, taking a minute to calm down and moving on can actually reduce your pain perception. It's real. Things like cognitive behavioral therapy with a good, well-trained therapist can be helpful. There's always modalities like massage therapy, acupuncture, topical preparations like ice or hot, or icy irritants like icy hot, kind of the menthol topical preparations. They actually kind of distract your brain a little bit from the pain. Sometimes pain is improved with increased physical activity. A lot of the kind of achy pain that people get from their chemotherapies is inflammatory. And the best anti-inflammatory is exercise. So making sure that within the ability that your body tells you, so listening to your body about what you can and can't do, what your limits are, you want to increase your physical activity as much as you can and work little by little to increase that physical activity as able. Things like positioning and ergonomics, using things to distract yourself from your pain. And like I said, the interventional strategies, like there's some kinds of injections and things that can be helpful for certain types of pain. So all of those things are things that can be done without medications. Next slide. How are we doing so far? Any other questions? All right. So I'm going to talk a little bit about the frequently used medications that we manage pain with. And I kind of whipped through these really quickly when I was talking about the different types of pain. But in that mild to moderate pain, we're really looking at Tylenol as kind of the mainstay, as long as somebody's liver enzymes are functioning well. And I don't think there's too many medications that treat cancer that have an interaction with Tylenol. But as long as you don't have an interaction and your liver enzymes are healthy, using 1,000 milligrams of Tylenol every 6 to 8 hours, we think the safe max is probably closer to 3,000. For a long time, we really thought it was 4, but now we're kind of backing it out to 3,000 a day. You can use that for a long, long time and not cause problems. For people that have like arthritis pain, taking 1,000 milligrams of Tylenol might not be all that helpful. But if you take it 3 times a day, data says it works better. So some of these meds have to be kind of used more frequently. When you get into the more moderate to severe pain, and this is mostly somatic pain, I'm not talking so much about neuropathic pain in this slide. The ibuprofen and naproxen sodium, they're over the counter. The doses we often use for cancer pain are higher than the over-the-counter doses, but you want to make sure you're talking to your provider. We have to have healthy functioning kidneys. We shouldn't have blood thinners. Our platelets shouldn't be low. You shouldn't have a lot of GI distress or reflux because that increases your risk of GI irritation and bleeding. So there is kind of a sweet spot for these meds where they can be really helpful, but there's a lot of things we have to be thinking about when we recommend them. And then when you get into that moderate to severe pain, I did mention the opioids, and the most frequently used opioids are hydrocodone, which is Vicodin, or Norco is the other name that people recognize it as. Oxycodone, morphine, something called hydromorphone, also known as Dilaudid. We use fentanyl, we use methadone. These are all medications that are very strong and potent, but can be dosed, by a good provider, hopefully in such a way that we can manage pain without causing significant impact from the meds. So I tell people all the time, we're looking between these two areas. We want the pain to be managed well enough that the pain isn't causing you to be limited by your function. And we don't also want the pain medications to limit your function. So that's kind of the tip of the sword right here. And sometimes it takes a little bit of experimenting and exploring to figure out what that looks like. Okay, next slide. So I'm going to talk a lot about opioids because opioids are the mainstay. They're not the only thing, but they are, for more severe or chronic pain, what we turn to. Once you get past the Tylenol and the ibuprofen, there's not a lot we can use. We can use something called tramadol, but there's reasons why that's not the best option as well. And so once you're past the Tylenol, the ibuprofens, then you're kind of into opioid territory. And there's options. There's long acting. So if people have chronic pain all the time, cancer related, then we can put people on a slow release medication. That's kind of nice. Leslie, you asked the question about, can people work? Yeah, one of the biggest challenges with chronic pain is using short-acting medications. You take a medicine, you have to wait for it to kick in and work, and then it'll work for a few hours, and then it kind of starts to wear off, and then you're kind of up and down doing this cycle. If that goes on long enough and we can demonstrate that you can use opioids in such a way that it doesn't make you overly sleepy, we can translate that into something that's kind of slow release. And that can be, a patch through the skin, or it can be a swallowed pill that has kind of a slow release component. And that can really even out and make that chronic, moderate to severe pain easier to handle. And we also have kind of short acting that comes in tablet or liquid. And, we would choose tablets most of the time, liquids if somebody is really struggling with swallowing, like say an esophageal tumor or something like that, or a head and neck cancer. I mean, there's reasons why we use liquids, or sometimes we'll use liquids if we're using, and we need a little bit faster onset for maybe episodes of pain. So, chronic cancer related pain that's moderate to severe, we're really looking at those long acting meds and then using the short acting meds as what we call breakthrough pain. So that term means if we've got you on a long acting med, our goal is that that's doing the heavy lifting for pain management, but we want to be able to use the shorter acting if, say, you get in the car and the car is really bumpy and that spikes your pain up, or you need to go be a little bit more active. And so we need to support that activity with a little extra dose. But we typically, if you're using more than 3 or 4 doses of breakthrough a day, we need to talk about maybe adjusting that long acting dose. And, we may need to add a component to it for that neuropathic pain that's non-opioid, like we talked about. And the other thing to think about is we always want to make sure that you're taking bowel medications if you're using opioids to prevent constipation. It's just much easier to prevent than to respond to after you've already become constipated. Okay, next slide. So I do want to talk a little bit about these high-risk medications and safety, not only around opioids. We use a lot of medications for like anxiety, lorazepam, sleep medications, these high-risk medications that in the primary care clinics, they're now requiring contracts for a lot of them. Contracts or kind of opioid agreements or high-risk medication agreements in the oncology setting are a little bit controversial. Mostly because, well, a lot of patients are so reluctant and hesitant to use them to the degree that their hesitancy keeps them limited in their function. So they're not out and being active and they're not doing the things that we want them to do to help them live well while they're living with their cancer. That you throw another barrier like an opioid agreement or a contract in it and people are like, ooh, if it takes that, then I just absolutely am not going to do it. But the flip side is we do have patients that come in that have substance use disorder histories or they're high risk. And we'll talk about the risk stratification here in a minute. And we do need to recognize that there are risks with these medications. The risk is not the same for everyone. So there's screening tools that we use. There's lots of different screening tools. I'll pop up an example of one here in just a minute. But the tools that we use to screen are to help us assess and then discuss what your risk might be. And screening everyone is totally reasonable. I think contracting everybody's a little bit overboard. Probably contracting with the moderate to higher risk patients makes more sense. Or if there's a patient that's really kind of demonstrated inability to partner well with following instructions, we may need to kind of pull out some paperwork and say, hey, here's the expectation of you, here's the expectation of me. We just want to make sure it's in writing, it's really concrete, because some people kind of need those kinds of boundaries. And I think at the very least, talking with your provider about these medications that are higher risk is really important. Addiction is a risk. And it's, like I said, it's not the same for everybody, but we do want to at least let you know, hey, that's one concern. The concern for, impact on cognition and reflex time, until you know how you feel using these medications, you need to be really cautious. We should be talking about that and making sure that you're consenting, you're aware of the risks and you're consenting to using these medications for the benefit of, and that's where we identify what we're trying to help you be able to do. That's where that functional goal piece comes in. I want to go be able to walk around the park every day. I want to be able to pick up my granddaughter and take her to, so-and-so's place, and creating those functional goals so that we know when we're in the sweet spot for any of these medicines. If you're setting these goals, you're using the medicines and you're like, yep, I'm able to do that. That kind of tells you maybe I don't need to take more, right? I'm right where I need to be. If we set those goals, we put a plan in motion and you're not able to do those things, then we need to talk about, should we be upping the meds or changing the meds up, somehow. Okay, next slide. This is an opioid risk tool. It's a little bit blurry here, but bottom line is there's a few questions about family history of substance misuse, personal history of substance misuse. An age factor and gender factor creates a different score. Things like history of pre-adolescent sexual abuse, psychological disorders like severe depression, ADD, OCD, bipolar, those things can alter your risk. And so you just get a little score here, and the score will tell me if there's no risk, mild risk, moderate risk, or high risk. And I treat a lot of patients that are moderate and high risk. It doesn't mean that they become addicts. It just means there's something that in their past or in their family's past sets them at higher risk. And so I generally talk to patients about that. We're pretty open about what that looks like and why it is. Okay, moving on. So we kind of talked before, goals for your pain plan, identifying a 0 to 10, and also identifying functional goals as a way to start. Tracking how you use medications, when you use them, how much it takes, how well they help can be really helpful to your providers to be able to know kind of what needs to change. Understanding your own risk score, if it's available, can be a really helpful thing for patients and families. Sometimes I have families that are really worried about their loved one because maybe they had another family member or somebody they knew that, started on opioids and had a bad outcome. And we can talk about, their loved one's personal risk score, and maybe it's low or maybe it's moderate. And what are we going to do to help protect them? Making sure that you truly understand what the expectations and instructions are around any medications. It's okay to ask for written instructions if you get stuff that's really complicated, especially with high risk meds, because you want to be able to use them correctly and not adjust. You want to make sure you're always having a conversation with your provider about what they recommend. And if it's not working, having them help you make safe adjustments. I have a lot of patients that, kind of like, well, I took 2 and it didn't work, so I took 3. It's like, okay, well, we need to have a conversation about that so that I can tell you whether 3 is an appropriate dose or not. And then here's an interesting thing, and this is for those high-risk medications too: sleeping meds, anxiety medications, pain medications. Safe storage is really important. Having those medications in a locked cabinet or a locked box is really important. It turns out a significant number of the medications on the street come from thefts from people in their own family, and a large percentage of opioids that go missing are stolen by family members or friends that you wouldn't necessarily assume. So as a responsibility to you and your families, but also to the community, we really recommend having these things locked up and stored away. Okay, next slide. Narcan is the antidote to opioid overdose. There is more encouragement for us to use that or prescribe that medications to our patients who are on opioids. I will say, whether an overdose is an accident or intentional, Narcan is the solution. And it turns out that actually having this in people's homes is a good idea, regardless of whether they're on opioids, because people's family, friends, and loved ones often have risky behaviors that they're not aware of. And we've had people, save people in the community with their Narcan that they had at home that they didn't need because they didn't have a challenge with opioid. So we are seeing more and more of that in the community. And I just put that out there because I don't want people to be frightened if their prescriber or their pharmacist recommends Narcan, because the pharmacist can prescribe that to patients without their provider's approval. That's a law in Oregon. And then the other thing is kind of being aware that high risk medications, so anxiety medicines, alcohol, sleep medications, opioids, heroin, any of those things getting mixed together increase your risk of overdose. So, it's not that we can't use some of these medicines together. It's just that we need to know how much you're taking. And sometimes we need to make an adjustment. I might have had somebody on lorazepam for their anxiety that keeps them awake at night. And then we start an opioid, but then maybe I'll back that lorazepam dose down a little bit because the risk of combining it with opioid is higher. So making sure that we're really aware and tuned into those things is important. Okay, next slide. PDMP is something that providers have. It's a database that allows us to access how many prescribers a patient has for high risk medications. It tells us the frequency and quantity of high risk meds that they've been given. That can tell us, who's been prescribing. There's some interstate data available, but really, some people look at PDMP as a way to kind of ding people for overuse. I tend to think of this tool as something that supports a patient's story. So I've had patients who've said, no, my provider didn't give me medicine. And I was able to validate that, no, they weren't given the medicine that they were due because the PDMP didn't have that logged in. And so I really like to think of this tool as something that helps to support, my patient's story. If there are high risk things that are popping up, then I'm going to have a conversation with you and ask you like, hey, where are these other meds going, or where are they coming from, and why do you have them, et cetera, et cetera. Okay, next slide. So the key take home is that pain is really complex. It changes over time. The recommendations for how we treat it changes over time. You have to take the first steps in advocating for yourself. Showing up today is a part of that. Just better understanding your body, better understanding, the tools that medical professionals have available, how or why they might use them. I highly recommend anybody with metastatic anything to engage with a palliative provider if you have one available. Even if you don't currently suffer from pain or other debilitating symptoms, it's really good to have like a relationship with a knowledgeable advocate who can help if and when something changes. And palliative care teams do so much more than just pain management. We're not just pain management. We really are there to support patients and families and the existential distress, like I talked about earlier, of living with chronic illness. It's really big. It has an impact in all parts of your life. And having somebody who kind of understands that and helps empower you, or maybe helps empower family, or maybe helps just support the whole system that's wrapped around you. I think that's it's an underutilized resource. We're seeing more palliative providers and palliative care programs pop up, and patients are often kind of leery because they think, oh, it's just hospice, or it's just only when I'm really sick. And the reality is it can be for anybody at any stage who needs extra support while they're walking through life with a chronic illness. So that's kind of my plug for palliative care. Next slide. I think I was going to say, I think we're just about at the end. I covered a ton, but I know there's stuff that I didn't cover, and I'm really curious what you guys are interested in understanding more about.